So I'm going to say good morning. I'm Ber Grogan. I'm the Executive Director of the Simon Communities of Ireland. If this is your first Simon Talks, thank you for joining us. The chat function isn't open, but the Q&A function is. So please feel free. We'll have a Q&A session at the end, but if things are coming up during the webinar, feel free to put them in the Q&A box, and then after Brendan's presentation, I'll come out and we'll have that discussion. And just as usual, Brendan thankfully reminded me there, it's been a while since I've done a bit about mental health, but we are going to be talking about difficult things. And we know that some of you who are registered to come along today are frontline practitioners in housing and homeless services and may have experienced some very difficult situations, as well as the people that you're working with or supporting who may have experienced suicidality and things. So if anyone needs to stop listening to Brendan or myself, step away, get a cup of tea, get some air, absolutely. And we'll share some of the support links at the end of the webinar as well. So please don't feel free, if anything is upsetting. And just to say as well, we're obviously going to be touching on the things around social inclusion and things like that. That's something that I learned from Brendan in my previous role in mental health reform of the types of the kind of poverty and injustices that he sees through his work as a consultant psychiatrist in Tallaght. Join the conversation online if you like with hashtag Simon Talks. We are on Blue Sky now as well, if anyone wants to get into that. Get involved in the Q&A afterwards, and like that we'll have Brendan's contacts. Don't expect him to be able to answer everything. And just to say as well, if anyone has specific questions about the new mental health bill, the main thing is that nothing is happening overnight. Probably not even this year or next year. There's a long legislative process to go through. I'm delighted that Brendan is here with us this morning. I got to learn lots from Brendan during my time in mental health reform, and those of you who are familiar with mental health will, I'm sure, have heard of Brendan. So this is Professor Brendan Kelly, Professor of Psychiatry in Trinity College and consultant psychiatrist in Tallaght, and just all round good egg for talking about all of this. Yeah, he's looking surprised, but I always learn something when I hear from Brendan, and I'm really looking forward to the discussion. So I'm going to be quiet for the next while. I'm going to mute myself, and Brendan, I'm going to ask you to share your screen and kick it off.
Great, thank you very much. Lovely. Well, look, thank you so much, Ber and colleagues, for inviting me along, and thanks everyone for attending this morning. It is a real joy, a privilege to be talking to you. I have profound respect for the work that Simon Communities do and similar organisations. So thank you very much for inviting me along. My name is Brendan Kelly. I'm a psychiatrist, meaning I'm a medical doctor who specialises in psychiatry, the treatment of mental illness and prevention, hopefully, of problems associated with mental illness. So I'm Professor of Psychiatry at Trinity College Dublin and a consultant psychiatrist at Tallaght University Hospital in Dublin and with the HSE as well. But obviously my views do not necessarily reflect the views of any of those organisations. As Ber said at the start, look, I'm going to talk about mental health, I'm going to talk about mental illness, self-harm, we'll move into the area of suicide as well. And I'm going to talk about all of these things in a fairly direct fashion. So I appreciate that with any audience, there will be people with different experiences professionally, personally, and always feel free just to tune out for a few minutes if something isn't quite landing with you and tune back in and see what's going on. But I do want to talk through these topics because we see them in our lives, and in your line of work, you're going to see, and I know you do see many mental health problems, mental health issues, mental illness, suffering, all kinds of things. So I'm just going to talk through a number of these. So I'm going to start with what is mental health, because we talk about this all the time. Then some facts and figures. I'm going to move on to homelessness and then some take-home points at the end. And this will all be kept within a half an hour. And I'm just so keen on questions and thoughts, particularly based on your experiences of these things. So, let's see now. Mental health, what is it? And this is always a question I ask the medical students in Trinity every year. I start with what is health? And the World Health Organization tells us health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So this is the World Health Organization definition of health. And I wonder how many of us can honestly say that we are in a state of complete physical, mental, and social well-being. And it does, of course, bring social issues into the realm of health by including social well-being as part of health. Now, that is general health. What about mental health? Again, the World Health Organization has a definition here, which is really quite similar to its definition of health. So the World Health Organization says that mental health is a state of well-being in which you can realize your own abilities, can cope with the normal stresses of life, can work productively, and can make a contribution to our communities. And in this positive sense, mental health is a foundation for well-being and community functioning. So again, there's an awful lot of talk about mental health and mental health issues and mental illness and so forth. And these are apparently the definitions we're supposed to work with. They are very, very idealistic definitions. Again, I'm not certain how many of us can honestly say we are fully realizing our abilities, cope with the normal stresses. Many people work productively, I guess. But the idea of making a contribution to the community as an element of mental health is really, really interesting. And I like it a lot because there is often a tendency to talk about individual mental well-being, which is valid, but maybe sometimes we don't recognize as much as we should that we live very much in community, very much in relationship. And we see this very interestingly in legislation, and I will touch on the mental health bill later on. But we see this in capacity law as well, where there's an awful lot of focus on the individual, which is right and proper, of course, but it tends to downplay the extent to which we are totally reliant on other people. We are not standalone individuals. We're very much, we exist in relationship. So those definitions of mental health tap into that. So what is happening then in the world in relation to mental health? I guess we are very accustomed to hearing about mental health crisis and problems with mental health, particularly in specific groups. But I'm going to stand right back from all of that now and look at the world in general, the whole world. And we will start with happiness. Let's start with some really positive mental health today before we move into other things. Each year we have a World Happiness Report, and it ranks countries in terms of happiness. And I'm thinking, we don't have a chat function. So I'm thinking you can guess the happiest country in the world is pretty much always Finland in recent years. And at the very bottom of the table then, Afghanistan. And you can see this is asking people, about their happiness, rating their own well-being. And people in Finland tend to rate their well-being as very high, and people in Afghanistan tend to rate it as very low. And you can immediately see, and it's always apparent, that rich countries do better. Also, stable countries do better, like Finland and the Scandinavian countries, whereas countries that are politically unstable and socially problematized in various ways tend to come out. People rate their happiness as much lower, as we see there with Afghanistan at number 147. So that's the bottom of the table. Where is Ireland? We are always around here, very near the top. Ireland is a rich country, a stable country, and we tend to rate ourselves as pretty much as happy as Finland rates itself. So we tend to be 15th from the top in the happiness stakes, insofar as these statistics mean anything. These are obviously averages, and they're interesting enough. They're not everything. I guess maybe the most important aspect here is that we tend to be ahead of various other European countries, but the Scandinavian countries are usually up top. What if we shift away from happiness and look at the other side of the spectrum? How does Ireland do in terms of, say, anxiety and depression and so forth? I'm going to put up a graph now, and this is the most recent reliable data. And this is asking people across many, many countries, have you ever been so anxious or depressed you could not continue your regular activities for 2 weeks or longer? So this is a question asking people not so much about the ups and downs within a given day, but asking people across many countries that really, have you been disabled by anxiety or depression for 2 weeks over the course of your life? And so quite a significant level of a psychological problem or problems with mental health. And when you look here in the United Kingdom, for example, 26% of people say that at some point in their life they had a 2-week period when they were substantially disabled by anxiety or depression. It's a little bit above the EU average, European average. The US is a little bit lower, and across the world a little bit lower again. What about Ireland? You can see that our rate is, I'm not going to say low, because 17 or 18% of people, that's a lot of people saying that they had a 2-week period. But it is a little bit lower than average, and it is similar to Finland. So as we see again, the effect that certain rich countries, certainly like Ireland and Finland, tend to cluster together. So in terms of overall mental health, have you ever had a 2-week period of anxiety or depression that was, disabling in your life? Around 18% of Irish people will say that that was something they experienced, and that's similar to the world average, and it's a little less than the European average. So that's one indicator. So about 1 person in 5, about almost 20% of Irish people will report such a difficult fortnight at some point in their life, and that's a lot of people. So it's a high number, but not as high as in other countries. What about other statistics here regarding mental health? And again, look, I'm going to move into some statistics about self-harm, again, getting a little more serious, and then into some statistics about suicide. And I do want to start by saying that I appreciate that things like self-harm and suicide are intensely personal matters. And if you're a person who has been bereaved by suicide, or maybe someone you're working with has self-harmed or died by suicide, I understand statistics really don't capture what that's like. Nevertheless, I do think it is important we look at what's happening. Are these things increasing or decreasing? And if we start by taking a little look at the most recent report from the National Self-Harm Registry here in Ireland, this came out just about a month ago. They look at the rate of people with self-harm presenting to hospital. Now, I know this is a feature for many people who work with people who are homeless, people who have housing instability, and so forth. The rates of self-harm are elevated, but this is looking nationally at Ireland, the Republic of Ireland, in 2022. There was about almost 200 people per 100,000 population presented to hospitals following self-harm. So that's 197 per 100,000 population in 2022 presenting to our hospitals with self-harm. 2023, you can see it down slightly, but it's probably about the same. Maybe a little trend downward there in self-harm. But the overall picture is that generally speaking, this rate is slowly falling, and compared to back in 2010, the rate of self-harm presenting to hospital is now 12% lower than it was, so that has diminished. Now, that is just one statistic. There are other ways of looking at and measuring these things, but it does appear that the rate of self-harm presenting to hospitals in Ireland is overall declining, and this is partly due to a number of things, one of which is probably the deliberate self-harm program in the emergency departments, which is helping to reduce harm in this way. So that's a relatively positive indicator, although to emphasize yet again, the number is still too high, and but this does suggest that it can be brought down. It can come down with good care and good support and good management. So again, moving towards the more serious and concerning topics and statistics, I want to take a little look at suicide, and this is World Health Organization data. And if you look at this graph here, this is the year 2000 up until 2021, which is the most recent year for which there are reliable data. And you can see here this line that you can see a reduction in the global rate of suicide from 13.6 per 100,000 people per year down to 8.8. And you can see a reduction in Europe as well, that over this 21-year period, the rate of suicide falling quite dramatically, really, in Europe, and falling very significantly overall. And the world includes Europe as well. We just took Europe out because it's of interest to us. What about Ireland? You can see here in a sort of a pink color, Ireland's rate of suicide is lower than the world average and much lower than the European average, and has also fallen in the 21-year period here, at the decline of about 35%. Now, with this statistic, I really do want to emphasize that each suicide, every single suicide is one too many. And I am not in any way suggesting that this kind of progress is sufficient. Statistics mean nothing if you are a person bereaved by suicide, or if you yourself have been in that state of mind where you were thinking about such things. Nevertheless, what the global numbers show very, very consistently is that positive change is possible and is happening. And my view is very strongly that if the rate of suicide in Ireland can come down by a third, then it can surely come down by another third as well. No one is born wanting to die by suicide, and this should be something we can fix and get the rates down far, far lower than this. And the numbers over recent decades indicate that it is possible to do this. There is nothing inevitable here. We should be able to make more positive change. Some countries are going the other way. You can see a slight increase in the United Kingdom there, and perhaps the most dramatic counter trend here is the United States, where you can see as rates of suicide are falling overall in the world and in Europe and in Ireland, you can see an increase in the United States. Now we could talk about that again at another time if you wanted, but just to emphasize yet again that there is still a very serious problem with suicide and self-harm. And we need to work harder. And indeed, these numbers, what they say is we must work harder, because this is an area where clearly there can be positive change. There is nothing inevitable here. Change is possible. So my last of the statistics I want to mention concerns the use of medication. And again, this is something we hear about from time to time in the media. Often the reports are that there are increases in prescription of medications for mental health problems, that there is overuse of medications. So this is, again, looking across many countries. And the question here is, among people who said, you remember the previous question, among people who said they were so anxious or depressed that they couldn't continue their regular activities for 2 weeks, those people were asked, did they ever take medication to help with that? So this is among people who had that 2-week period. This is not a population number. This is among people who had 2 weeks of severe anxiety or severe depression. Did they ever take medication? And there's a bunch of countries here. You can see here in the United Kingdom, 78% of people who had been anxious or depressed for 2 weeks took medication. Various countries have lower rates. And here I've put Ireland near the bottom because it's 63%. So that means in Ireland, among the people who had 2 weeks of severe anxiety, severe depression, about 63% of them have used medication to help cope with that. I suppose the point I want to make here is that this is very standard internationally. We are not high users of antidepressant or anti-anxiety medication here in Ireland. We're a lot lower than many other European countries, or a bit lower anyway, and we are bang on, we're just there in the mix of countries taking medication. So this is generally for the population as a whole. I am talking today to people from the Simon communities. So I just want to present one or two, just one last slide of numbers about this really interesting study. I don't know if any of you were involved or know the people involved. Really nice paper that's free to access online by these authors, Homelessness and Health-Related Outcomes, a systematic review, meta-analysis and evidence map. And it's in the Journal of Public Health just last year, and this is free to access online. I've just put out a couple of the mental health statistics here, and you can see that homelessness is associated, and you will all know this, with increased risk of drug misuse. That's a 7-fold increase in risk there. Reduced access to a GP and all of the negative consequences of that. Emergency department attendance, look at that, 28 times more likely to present to an emergency department if deemed homeless. And repeated presentations with self-harm and premature departure from hospital. So you've got a perfect storm of problems that come together, which is the drug misuse, mental health problems, reduced access to a GP, therefore increased reliance on emergency departments, and repeated presentations with self-harm, and then departure from hospital before the episode of care is complete, and that's often due to delays in the hospital process and delays in the procedures at hospitals. And of course it snowballs when people are presenting for these reasons. Before I move on a tiny bit more to homelessness, I just want to say a quick note to some of you who might be working in settings where you meet people and talk to people who are having thoughts of self-harm, and just a tiny little bit of advice about that, if that's okay. Because often the people you'll be seeing are in very difficult, challenging social situations, and a lot of the stressors and the problems you won't be able to fix there and then, or should have been fixed 10 or 20 years ago, but we are where we are, and we have to deal with the situations we're in. So in relation to self-harm, it's useful to look at it a little bit like this, that there is a certain percentage of people in the population who are absolutely sort of happy and want to be alive, and they've absolutely no doubt. And then there's a certain percentage as well, this is in the red, who have very severe thoughts of self-harm. But in the middle, there are people who are having occasional thoughts of self-harm, or what we might call a passive death wish, who maybe don't want to end their life, but don't see a lot of point in living. And it's this very large group in the middle that have this changing ideation. Certain factors will push, like drug misuse and alcohol misuse and social problems will push them one way, but your interventions working with this population will absolutely move them in the direction of that green arrow. And I just, there's 2 points from this slide, which is, when we ask people, are you having thoughts of self-harm or harming yourself, we should not expect a yes/no answer. We should allow people to explain where they are in that big yellow box in the middle. And even by allowing that explanation and listening to that explanation, you are working with the green arrow there, which is pushing upwards, pushing people back into the carrying on, back into the dealing with problems and away from the thoughts of self-harm. But the big point is to allow people to be in that yellow area and not necessarily push them for yes/no answers to questions about self-harm, questions which are intrinsically very, very complex indeed. So I'm only going to talk for a few more minutes. I want to touch on homelessness, because when Ber and our colleagues in the Simon communities asked me to do this talk, I was really pleased, because I had written a paper many, many years ago, and to my absolute horror, it turns out to be 20 years ago, that I wrote this. And some of you would be familiar with the idea of structural violence, which is essentially the idea that the way society is structured, the way our processes and systems have evolved, is they don't give everyone an equal chance. They don't, and this isn't something that we do as individuals, it's something about the way our social systems and structures have evolved, or we've let them develop over many decades or centuries maybe. And so this paper was very much looking at that notion of social, economic, and political factors, along with stigma, that constitute a form of what I would call structural violence that impairs access to psychiatric care and social services and amplifies the effects of mental illness. In this case, I was talking about schizophrenia. So, while schizophrenia exists as an entity, the disability and problems that are associated with it are magnified enormously by a set of social, economic, and political arrangements that that never give people with schizophrenia an equal crack at things. Um, and as a result of these overarching social and economic circumstances, people with schizophrenia, and look, you could put in bipolar disorder or severe depression there as well, are systematically excluded from full participation in civic and social life and constrained too often to lives shaped by stigma, isolation, homelessness, and denial of rights. And look, we see this all the time in mental health services, and we are very much aware of this as we try to use the resource we have for the treatment of mental illness. But, the resource that we have in mental health services does not allow us to address all these people's needs. Here, where I work in Tallaght, two of my colleagues, John Cowman and Peter Whitty, looked at the prevalence of housing needs among inpatients. This is almost 10 years ago now. In other words, for a year, looked at all the people admitted to our acute unit here in Tallaght Hospital. And they found that 38% of our psychiatry inpatients had accommodation-related needs. And most patients whose discharge was delayed beyond acute mental health need, this was attributable to a lack of accommodation options. And of course, this commands an opportunity cost, because if beds for the treatment of acute mental illness are occupied by people whose acute mental illness is treated, it means other people who are presenting to our emergency department cannot get the treatment they need. And of course, this is not just Dublin. We tend to talk about Dublin all the time, but there was another study, this is more recent, 2022, by Noreen Maloney and others, including me, I think, showing something very, very similar. And so very often we are aware that we're discharging people from acute psychiatric care into homelessness, but we simply do not have the tools to organise accommodation for everybody, despite the best efforts of our various social workers. The key issue for us in mental health services is this. This is the number of hospital beds per 100,000 population across the EU. And you can see here the average is 73 psychiatric beds per 100,000 population in the EU. Some countries like Belgium have nearly double that, but here in Ireland we have an exceptionally low number of psychiatry inpatient beds. So for those of you working in hostels and services, where people are not getting admitted to mental health services or are being discharged very, very briskly indeed, it is very much because we have other people with acute mental health need presenting in need of acute mental health care, and it's a matter of balancing up access to services and using the mental health resource we have as best as possible. And as you can see there, the bed numbers are low here in Ireland, as is our admission rate. So that's just, I guess, a few points about homelessness and awareness. So for the last couple of minutes, I want to give you some take-home points, and I will touch on the mental health bill briefly here. So first, for yourselves working in the jobs you work in, the idea of self-care is incredibly important. You're working in an area of infinite need, but finite resources. And the task of distributing that resource as best as possible is a difficult one. So looking after yourselves is important. And being aware of the purpose and the meaning of what you do, which is incredibly important, because it is almost impossible to treat many kinds of mental illness if a person is constantly homeless or moving accommodation, changing. It is so hard to establish therapeutic relationships, and this can be very frustrating. So I was most interested to note awareness of this. And for the Galway Simon community, I'm from Galway, so I was looking this up. This looks like a fantastic initiative. I know there is similar happening in other parts of the Simon communities around Ireland, and this kind of thing is strongly, strongly encouraged, because often we don't notice the pressures we operate under. So it is important to take some time for yourselves here. For other people, look, housing matters more than most things in relation to the treatment of mental illness, particularly enduring mental illness. Without that stability, it is challenging, not impossible, but challenging to treat many kinds of mental illness, most of which should be treated in primary care in any case, and GPs tend to be very good at this. As you will know, the mental health system, the sort of general adult psychiatry mental health teams are arranged on a catchment area basis. This is predicated on people having an address, and many people don't. So different parts of the country have different arrangements for this, but it is generally unsatisfactorily addressed or resolved, because the system is fundamentally based on a person's address and teams covering defined catchment areas. The purpose of that is to ensure an even allocation of resources, but it does make it particularly difficult for people who do not have a stable address or change address quite a lot. Many of the people you see might end up in prison from time to time, and incredible as it seems, the provision of mental health care in prison is even more difficult, and it should not be seen as an opportunity to access care, as it sometimes is. And the final point I want to make about the broader scheme is that legislation, the law, can change and will change, but it's not going to solve this. No matter what changes are made to legislation, it will not solve the challenges of providing reliable, sustainable mental health care to people who are homeless. We currently have the Mental Health Act 2001, and that piece of legislation focuses on two things: ensuring quality of services and regulating involuntary admission and treatment. It's probably worth noting that Ireland's rate of involuntary admission and treatment is very low internationally. It's less than half the rate in England, for example. But nevertheless, it does need to be properly addressed and rights protected in that process. And that's what the Mental Health Act does. This, what I've got on the screen now, is the Mental Health Bill, and this is a proposed change to legislation. This again focuses mainly on the areas that the current legislation focuses on. It looks at inspections and regulation, and it also makes various changes to involuntary treatment. Unfortunately, it does not provide a single euro more for mental health services. It does not include a right to access mental health care, which other countries have included in their legislation. So it's not impossible to do. What it does is it does increase, were it to be introduced as is, it would greatly increase the amount of time that mental health professionals would spend in court and meeting various administrative requirements. It does not provide a single euro more for mental health services, unfortunately. So the bill isn't enacted, it isn't commenced, nothing like that. It will need to go through the committee stage yet, and will hopefully be significantly revised. I'm not going to get into details about it here, but it is worth noting that it mainly addresses the two areas that are addressed in the 2001 Act, which is assuring quality of services with inspections and the commission and so forth, and secondly, making changes to the involuntary admission process, or rather the treatment after involuntary admission. And that involuntary part, our rate of that is low here in Ireland, and it will not affect most people with mental illness in the country. It is a matter of great regret that the bill was not more ambitious in providing some kind of rights-based access to care. We would certainly hope that would happen, although I've hoped for lots of things in the past and they haven't happened. So to finish, I have one very last slide, and this is, I call this one for everyone, but it's really for politicians and local representatives. And this is for when you're talking to anyone with any kind of decision-making power anywhere, particularly politicians. The question to ask them is, why do we have so little inpatient psychiatric care? So we don't have opportunity to give people time to recover and really get their psychosocial care in order before they leave hospital. Things like substance misuse treatment, accommodation, and other supports. Why is it all really concentrated, really acute care for severely mentally ill people and then discharge and before they're ready for community services? So that is a question to ask. And the next question to ask politicians is, why does mental health get 6% of our health budget when Sláintecare recommends 10% and the UK 13%? So this is a really big question and we need to ask it again and again. And here's an extra piece of advice, if you can read that, which is, do not accept answers that use the phrase record funding. Politicians love saying that, but remember, if funding was grossly inadequate one year and there is a single euro added to it the next year, then it's record funding. Funding is inadequate. It is not what the government should be providing. It is not what should be happening. And these are the two questions that we should ask every politician we see. Why do we have so few acute inpatient beds, so we have to discharge people so promptly in order to make way for others? And the bigger problem is, why does mental health care only get so little of our health budget? It is inadequate. It doesn't matter if it's record funding. That is a relative measure. It doesn't mean anything. And mental health reform, it's really worth checking out their website. They have lots of good information about this, really good campaigning, keeping this on the political agenda publicly and behind the scenes. So those are your two questions overall. So what I wanted to do today was talk a little about definitions of mental health, which is very idealistic indeed, but there we have it. I wanted to talk through some facts and figures to show that we tend to rate ourselves as quite happy in Ireland. Internationally, the proportion of population who report severe anxiety or depression, it's a little low or else average. The proportion of those that use medication is a little low or else average. There is good news in terms of positive developments with a partial reduction in global rates of suicide, and Ireland is part of that bigger movement, and maybe a small decrease in self-harm presenting to hospitals as well. What this tells us is not that these problems are solved or anything. What it tells us is that positive change is possible and we should redouble our efforts. The area you folk work in, homelessness, is a real opportunity to make positive change in this regard, because there are lots of fixable factors, you would think, in this population to do with social inclusion, to do with providing housing and supporting appropriate housing for people and appropriate supporting employment, training, and so forth. We know that these social factors drive down rates of self-harm and rates of suicide. So it's so important that there is a focus on this population, a high-risk population. And while it can feel frustrating dealing with a high-risk population at times, in many ways that's the only job worth doing. If work doesn't feel impossible from time to time, then maybe we're not pushing ourselves hard enough. And I know that it can be very challenging in lots of the circumstances where you work. So a little bit about self-care there, but I know that your organization has an eye on that, and I guess what I'm saying is pay a little more attention to it. You can't pay enough attention to looking after your own mental health. And for my mental health, I have a picture here of Croagh Patrick, taken from the village of Newport, one of my favorite places. And if you have a very close knowledge of the Mulranny Newport area, you will know that photograph was taken from St. Brendan's Well, a holy well just outside Newport, looking across to Croagh Patrick, which is the place to go for some beautiful mindfulness moments. A couple of books here. I'm going to particularly point to the second one there, The Modern Psychiatrist's Guide to Contemporary Practice. Its title isn't exactly inviting, but it is free. It is a free book to download, talking through this, and I have a chapter there about solutions in terms of structural violence. In other words, the social factors that perpetuate cycles of injustice and social exclusion. And if you want to read about it, you can download the book. It's free. You don't have to register or anything like that. And it maps a lot onto the work that you folk are doing. And if you remember that picture of people who want to self-harm and those who don't, you really are pushing pushing people towards, away from self-harm and towards a solution-focused approach with the work that you do, for which I have huge admiration. As I say, you can download the book. I chat about it there, and the book is free, so there's nothing in it for me. So look, I'm going to stop sharing the screen now, and thank you very much for listening, and I'm very happy to answer any questions or have a chat. So thanks a million. Over to you, I think, Bar.
Thank you so much, Brendan. That was I was nodding along at some parts and smiling along, and you got all the great messaging in around the funding and the resourcing as well. I'm delighted to see that there's another book to add to your list. That's my weekend reading now, sorry. We have, so just to remind everyone that the Q&A function is open. So just one question has come in. So sorry, someone during the talk had said about the suicide statistics, and I just did a very brief answer saying that obviously here, you have to go through the coroner's court, and a coroner has to decide whether the cause of death was suicide, or maybe it was, misadventure or other things. And the person had mentioned about like single person car crashes and things like that. So I suppose the thing is we don't have 100% accurate statistics. Yeah. And I know HUG, the suicide bereavement support charity, have done some work on that.
Yeah, so Bar, just to come in on that point, obviously, like all statistics, the statistics about suicide are imperfect, and there are things like single vehicle car accidents. Now, just to emphasize again, talking about this in terms of statistics, I'm just doing this to get an understanding. It is not in any way it's not to sound cold or to sound callous, and I hope it doesn't come across that way. But when you look at the number of fatal single vehicle accidents, it is very low. In most years, it's less than 10 or 20, and so that's unlikely to be having a major effect on statistics. But the questioner or the person who made the comment is absolutely right. We shouldn't get too attached to the numbers, which is why the important thing is to look at the overall trend. And we can see a trend in virtually every country apart from the United States, which we won't get into. But we can see a trend in many countries, and the trend tends to be downward, and reporting, if anything, is improving. So, I wouldn't get too hung up on specific numbers. I'm very interested in trends. And the only thing I take from those suicide statistics, and they are coming down, all these many different sources confirm this, is that nothing is written in stone. We can make positive changes. It is happening. And we've as humans, we've this habit of pouring attention and resource into intractable problems. Whereas I think we should shift and say, look, here is something that clearly can change in a positive direction. So why don't we really load resources and attention into this? Because we know that positive change is possible, and we need to do a whole lot more, because even a single person dying by suicide is too many. And the evidence now is we can bring that number down.
Yeah, and I really like that messaging as well. And as you said, the evidence is there showing that the trends can come down. We've a question here about the overlap, and I don't know if you'll know this, between homelessness and neurodivergence, if there is one.
So this is really interesting question. And look, as I think the questioner probably knows deep down, we don't have reliable numbers about this, because recognizing and describing was it neurodivergence, Ber? I'm just going to use the phrase that the questioner used, if that's okay.
Yeah.
Sometimes the phraseology can become sort of difficult here. We don't have reliable numbers on the overlap between neurodivergence and homelessness, because we don't have reliable numbers regarding neurodivergence, generally speaking, as a concept. We have slightly more reliable numbers about concepts like autism and maybe ADHD, or attention deficit hyperactivity disorder. But that's still very much in a state of flux. And I think that recent weeks, some people might have heard a lot of talk about overdiagnosis, underdiagnosis, and so forth, and that all isn't resolved. I know what I see is I see people who have ADHD and were not diagnosed and really would have benefited from diagnosis. So if you like, that person was underdiagnosed. But I also see people who have received a diagnosis of ADHD, but when you go into it with them, what they have is an anxiety disorder or obsessive compulsive disorder. So that person was overdiagnosed. So I think both things are going on, and until we're more settled in that, we won't know about the overlap with homelessness. That being said, my experience, and I'm old enough now that I can say things like in my 20 something years working in psychiatry, is I believe there is a very big overlap between people with what I might call very significant neurodivergence, or let's say problems with neurological or cognitive functioning, and homelessness. And again, that is not, they are not inevitable accompaniments. These are because of a lack of reasonable accommodation for these people navigating the social welfare system, the housing systems, the medical systems, in the sense it's that structural violence again, which is the systems that are not designed to facilitate these people achieving the rights, the social rights that they should be achieving. So I think there is a big overlap, and I guess that's what the questioner was hinting at as well, but I'm not aware of numbers.
Yeah, and I suppose just when you're talking about rights and everything as well, be remiss of me not to mention the UN Convention on the Rights of Persons with Disabilities, and how, psychosocial disabilities, or people with mental health difficulties, do have rights under the equality legislation. I'm just seeing here, sorry, Stephanie has said about the stats in acute presentation. So she works in homeless services in Limerick, and there's nowhere to present for crisis except A&E. And clients can spend 24 hours on a trolley and leave before they're seen, and they're not recorded in the statistics. And then, yeah, obviously in the West, lack of community services, so people are going untreated. But if you can pay, there are services, and I suppose that's what we've seen, and I'm sure you've seen a lot more than me over the years, where there's a two-tier system in accessing support.
Yeah, I mean, in relation to the point about the acute presentations, yeah, absolutely. The numbers that I presented were, hospital presentations with self-harm, and very clearly labeled as such. And of course, a lot of people who self-harm don't present anywhere. Some people present elsewhere, and some people present to hospital and don't wait, like the other study showed premature leaving of hospitals. And it would be great if there was somewhere else for people to present. So, not least because a lot of self-harm, it's not, if you like, core mental illness or medically driven. An awful lot of it is to do with acute social circumstances. So the mental health policy, A Vision for Change, envisaged crisis houses for people who are presenting, not necessarily with an episode of schizophrenia, but more with a series of social problems that have suddenly become acute and led to a feeling of despair. Medicalizing that is not always helpful at all. And as we can see, it leads to people not presenting or going to emergency departments and then leaving. I know some hospitals are looking at information packs or supports for people who present with self-harm but can't wait to be seen because of the overstretched emergency departments. And I know some other services have community mental health nurses available at weekends that allows people to fast track in the emergency department system and be referred, say, oh, if you go home, or if you have a home to go to, indeed, that our community nurse will visit you this afternoon. And some services can do that, including, I'm very happy to say, the service I work in.
Yeah. Sorry, there's more questions coming in, and I know we've 10 minutes left, so I'm going to go to Joe had said about I wonder what the impetus behind the current bill, and is there anything of merit in it for the homeless population? And I suppose just on that, I'm going to say that it was reformed because the previous one was, you know, quite outdated, and you know there were some, we needed to bring things more in line with the UNCRPD and certain human rights frameworks and things like that. So there are some things to welcome in the mental health bill. But yeah, so in your opinion then, is there anything of merit in it for people experiencing homelessness?
There's nothing specific in it, specific to the people experiencing homelessness. It does focus very much on quality of inpatient services, and it extends a little bit into the child and adolescent mental health services, and then some really very technical details about people who are detained in hospital against their wishes, but nothing specific in relation to the nothing specific in relation to the homeless population apart from everybody else. I mean, I mean, there is a part of the bill that says no one should be kept in hospital against their wishes solely because they need a secure place to live. But that's neither here nor there in relation to the question.
Mm-hmm. And I suppose with stuff around the Assisted Decision Making Capacity Act and consent policies and things like that, you know, the HSE and others would encourage people to have those conversations with people accessing their services if they're, you know, in supported accommodation or linking in with key workers and caseworkers, you know, to have those conversations before someone might become so acutely unwell.
Yeah, and part of that conversation is the capacity legislation, as you correctly say, it does offer advanced healthcare directives, and these are underused, but they can be a very useful way of protecting the rights of a person and observing their will and preferences in a more robust way in challenging circumstances.
Yeah, thank you. So Mary is saying we've become a trauma-informed organisation. Clients often report a lot of childhood adversity, but are often diagnosed as mentally ill, however. So there's a question about childhood adversity. So it's the ACEs really, isn't it? Adverse childhood experiences and mental health difficulties.
Absolutely. Look, adverse childhood experiences and trauma increase the risk of pretty much all diagnoses later in life. Whether it is useful to describe these as mental illnesses or consequences of trauma outside of the whole mental illness paradigm will depend from person to person. I really like the phraseology that was used there, a trauma-informed organization, because being informed about trauma is incredibly important. Now, sometimes we hear that all mental illness is due to trauma, or all psychological problems are due to trauma, and all therapy should be trauma focused. That is not always appropriate for everybody, but trauma should always be considered. Care should be informed by trauma, and for some people, indeed, a trauma focused approach at the right time and in the right place is exactly the only thing that will help. But for other people, being 100% trauma focused might not be the right thing now. So I really like the phraseology of a trauma informed organization.
Yeah, and it comes back to, I suppose, as well, the social determinants of health, and if people are growing up in intergenerational poverty and social exclusion, and you use that so well through the presentation around the structural violence and the exclusion and the marginalisation of people, and obviously that all feeds into people's experiences in childhood. Breffney has a question here, and it's actually something I was thinking during the presentation, so I'm really glad they've asked it. So it's about the third lowest number of psychiatry beds per 100,000 population. So you had said people are being discharged too soon if they have social needs around addiction or housing due to a lack of acute beds. But they're concerned that by advocating for more acute beds, it would funnel resources away from developing support and accommodation services in the community. And I suppose I was thinking that as well when you were saying about the acute beds. I was like, or, you know, the step down facilities in the community. But I suppose that's part of us kind of, with the lack of resources, is pitting, you know, pitting things against each other. But there's yeah. So just what are your thoughts on that one?
Let's not let that happen, that pitting bits against each other. I mean, there is obviously an even greater need for the community services that would reduce the need for inpatient beds to begin with. But what I see is that there is a baseline need for inpatient care. There are circumstances when it's needed, and the current supply of beds is not sufficient to meet that. Obviously, there needs to be vastly more by way of community services, and particularly substance misuse services as well. And I know the recent iterations of the mental health policy have spoken about merging substance misuse services with mental health services, and like that makes 100% sense, because like so many people that we're treating have both issues. So in response to the question, I should have emphasized more that obviously I feel the need for community services that can reduce the need for inpatient beds, the need for accommodation services as well. But I do think inpatient is part of that as well. But I should have emphasized the other equally or more.
Yeah, and I think that's the thing, isn't it, as well, is that it's in an ideal world where we would have more resources available, we wouldn't have this thing of it's either or, and people would be getting the supports earlier in the community, so they might not need that inpatient stay. I've just answered someone. I've just sent them my email because it's quite a specific piece about a former tenant that they had worked with, and I'd just be concerned about kind of breaching the person's privacy rights and all of that kind of stuff. But if you email me on ber.grogan@simoncommunity.com, I will very gladly send you information about the kind of supports that you could be accessing for that person. And then just the other one was about the connection between mental health and community. Are there ways for people experiencing homelessness to access community? And I suppose I'd obviously jump in and say the work of the Simon communities around Ireland, gives that. But just from your experience, Brendan, what would you say?
Look, community matters enormously. We are not individuals in any kind of meaning, psychological or emotional sense. Our degree of connectedness is extraordinary. There are these brain cells in our brains whose whole job is to look at what the other person we're talking to does and do the same thing. These are called mirror neurons. We are practically biologically connected. And so this notion, and it's interesting, Barry, you're going to get very, very cross with me now, but the focus on individual rights is very necessary and long overdue, and it's the only way in law that rights can work. But we do need to acknowledge that most of our decisions are made with other people. We live with other people, and the observance of my rights and protection of my rights is also the protection of Ber Grogan's rights, and that we all move together on this. So I don't want to go all Buddhist about there being no self, but we are very, very connected with each other. You guys, you folk do the important work of creating community, and it's very much a feeling. I can't answer in terms of structures, but every time that you meet somebody who has accommodation problems or homelessness or whatever, and start treating them as a person and not as a problem, then that is community happening right there. And I know that is the ethos of Simon Communities from my contact with you in the past. And by doing that, you are embodying the change that is needed. That can only happen person to person, and I know that is part of your ethos to do that. And maybe some days you do it without even remembering you're doing it. But just remind yourself from time to time that you are doing the work of creating community, and you are doing the work of promoting mental health.
And you see, I'm not going to be angry with you at all, because I think that's a beautiful point to be finishing up on. And I completely agree, is to break down the stigma and shame that people might have around experience and homelessness. It's that acceptance, and the thing that we're all humans, we're all communities. No one's better than anyone else because of whatever they're experiencing, and to have that human level of connection, I think is something that can be really powerful. And I liked your point there about how I'm sure people are doing it without even thinking about it, because you're working in these areas because you care and because you want, as you said, to hold on to the positive changes possible. Brendan, I could talk to you all morning as usual. I just want to remind people about the HSE mental health supports that are available. So there's the free information line 1-800-111-888. You can obviously contact your GP, and there are a lot of online supports as well. So even if you just Google HSE and mental health, just if you wanted to talk to anyone after this presentation, and a couple of people are saying thank you, and yeah, so yes, thank you. And about community, yeah, exactly. It's not just geographical the accommodation units are their own communities as well, and people can find that, and people should be accepted by society at large. So I'm just going to say huge, honestly, a heartfelt thank you, Brendan. I think you spoke really, really positively and really sensitively about everything that we've discussed here today, and I really, really appreciate how you've done that, and for all that you're doing as well. And I'm sure I'll be on to you asking you to do something else for us soon.
Thank you for having me.
Thanks so much, and thanks to everyone for tuning in. The recording will be up online in the next couple of weeks on our YouTube channel. And thanks so much as well to Ailish in the background, who is organising the Zoom and the registration links. I can see her smiling. And to everyone for coming along. It's been really, really, really great. I can't see all of there's just, everyone is saying thanks. And very insightful. Just more things about how great you are, Brendan, you see.
Yeah, that's wonderful. But look, I honestly meant the work that you folk do is so important as a bedrock, and I'm just lost in admiration for all of you across Ireland. So thanks for tuning in.
Thanks so much. Have a great day, everyone. Get out and enjoy the sunshine and have some self-care today. Bye. Thank you.